Yeah, okay, sir. Thank you first to the organizers for choosing my abstract to do an oral presentation. Well, I'm Jon Izquierdo-Pujol. I'm a PhD student at Irsikashite Research Institute in Barcelona. And today I'll be presenting PBMC Immunophenotyping, plasma inflammatory profile, and antibody levels in children with long COVID. So, as you may know, we had more than 650 million COVID-19 cases worldwide, and there is an estimated number of 65 million people to suffer from long COVID. And we have listened a lot of talks about long COVID in adult population, but now I will try to answer what about long COVID in the pediatric population, right? So, just to be specific, there are a lot of hypotheses behind the pathophysiology of long COVID, but today I will be focusing on the immune regulation hypothesis, as my group is now working in this area. So our main hypothesis is that children and adolescents with long COVID have an immune dysregulation even after the acute infection is resolved, and we have three different objectives. The first one is to evaluate different PBMC levels of children and adolescents with and without long COVID through spectral cytometry. Then to evaluate the inflammatory profile of children and adolescents with and without long COVID, and last, to evaluate the humoral response of these children and adolescents. To do that, we have the PediaCOVID cohort at Hospital Jon Izquierdo-Pujol in Barcelona. In the PediaCOVID cohort, we have first the long COVID cohort with an N of 108 children, less than 18 years old. They have a SARS-CoV-2 infection diagnosed, either for antigen or PCR test, and they had at least 12 weeks of persistent symptoms, as the World Health Organization states for the definition of long COVID. Then we have a control cohort. The N is 23. In this case, we have divided the cohort in two groups. The first group, they got a SARS-CoV-2 infection, also diagnosed with antigen test or PCR test, but they were recovered, so they did not have any persistent symptoms after the acute infection, and the sample time point is 12 weeks from the acute infection to match with the long COVID cohort. And then we have another group where that they did not have any SARS-CoV-2 infection. So moreover, in the long COVID cohort, the median age was 13.8 years old, and 60% were female. There were no significant differences in both female sex and age between the long COVID cohort and the control cohort. Then the ones that they got symptoms had a median of 6 symptoms during acute infection, because the vast majority of the long COVID cohort was asymptomatic. Then the sample time point had a median of 20 weeks from the acute infection, and they had a median of 10 symptoms associated with long COVID. The symptoms with more prevalence were fatigue, neurocognitive neurodisorders, brain fog, headache, muscular weakness, dyspnea, myalgia, orthostatic hypotension, and insomnia. But we also had some cardiovascular symptoms as tachycardia, or gastrointestinal symptoms as diarrhea and epigastric pains, but they were less prevalent than the other ones. Moreover, the long COVID pediatric unit at the hospital, they did the PET-QL, that is a test that assesses for the quality of life of children and adolescents, and they saw that 37.5% of the children had their quality of life affected by this condition. Moreover, 45.8% were unable to attend school for full time, and more than 70% were unable to engage extracurricular activities, showing that long COVID is really affecting day-to-day life of children and adolescents that are diagnosed with this condition, and remarking the importance of studying this condition also in the pediatric population. So for the first objective, the characterization of PBMCs, we have preliminary results from the first 23 of the long COVID cohort and the first 19 of the control cohort. So we had PBMCs, and through a spectral cytometry with a 37-color panel, we were able to identify 53 different cell populations through manual gating. Of those 53 cell populations, 6 were significantly different between the long COVID cohort and the control cohort, where 3 were increased in long COVID, being double positive T cells, and 2 different subsets of memory B cells producing IgA, the CD21 negative and CD27 negative, and CD21 positive, CD27 negative. And then 3 were decreased in children with long COVID, being CD4 Temra cells and intermediate and classical monocytes. For the humoral response, we have data from the full cohort here, and we check in plasma through ELISA for anti-S2, anti-RBD, and anti-nuclear protein antibodies, both IgG and IgA levels. For the IgG, what we saw is that children and adolescents with long COVID had significantly lower levels of RBD, IgG, and we did not saw that in anti-S2 nor in anti-nuclear protein. So it was very specific of RBD. And then for IgA, we saw the same trend, where children and adolescents with long COVID had lower levels of anti-RBD IgA, and we did not saw that in S2. And in nuclear protein, as you can see, we only had 1 responder in the long COVID cohort and 0 responder in the control cohort. For the inflammatory profile in plasma, that it was the third objective, we also have data from all the cohort, and we check in plasma for 42 different inflammatory markers through Luminex and ELISA. Of those 42 inflammatory markers, we saw that 4 were significantly different between the long COVID cohort and the control cohort. 3 were increased in the long COVID cohort, being eotaxin, interleukin-15, and PDGF-AB. And 1 was decreased, that is, it was RANTES or CCL5. So a little bit of conclusion and outlook about what all the data that I shared now. For the PBMC immunophenotyping, we saw different immune cell populations that were dysregulated in children with long COVID. However, these results are from the first 23 of the long COVID cohort and the first 19 controls, so they are very preliminary, and now we are analyzing all the data from the cohort, and we are expecting the results in order to confirm if the preliminary results stay or not. Then for the humoral response, we saw that children and adolescents with long COVID had lower anti-RBD levels in both IgG and IgA compartment, and it was very specific of RBD. We did not saw that in S2. There was a paper in July that they saw that adults within the first 10 days of the infection with lower anti-RBD IgG levels were more prevalent to have past-core long COVID. So maybe this is happening in children, but they are not able to recover those levels. Then for the plasma inflammatory profile, eotaxin is increased in our cohort, and it also have been shown to be increased in adults with long COVID, having brain fog as a symptom. And brain fog in our cohort was one of the most prevalent symptoms that we have. So the results in adults are pretty similar with what we got. Then the increased PDGF-AB. Increased PDGF-AB is known to be increased in conditions that they have vascular damage associated. So maybe the increased levels of this cytokine, it's showing us that children and adolescents might have vascular damage. We did not assess that yet, but maybe in the future we will look into it and just corroborate what we got. And finally, interleukin-15 and RANTES are not described in long COVID, but just you to know, interleukin-15 is involved in the maintenance of cytotoxic cells, so the increased level of this cytokine is showing us that the body wants the cytotoxic cells to be maintained. And then RANTES CCL5 is important in T-cell chemotaxin, so maybe the decreased levels of RANTES together with increased level of interleukin-15 is saying that maybe there is some antigen or viral persistence in the body, but as RANTES is decreased, maybe the T-cells are not going to the site of the viral persistence. This is an hypothesis. And well, I would like to thank all the people that is involved in this project. Sara Moron Lopez, that is my mentor and the principal investigator in this project. Also Marta Massanella, that she developed the 37-color panel that we are using in spectral cytometry. The pediatric unit at Hospital Jon Izquierdo-Pujol, that they are with the children trying to solve and their problems through rehabilitation. The cytometry core facility at IGTP, where we run the spectral cytometry samples, and for sure the most important ones, the participants and their families, that without them it would not have been possible, and our funding sources. And thank you.